welcome again to another edition of the Osteopathic Lyceum podcast. I'm going to do something as what I'll consider a two-part series. It's not really a series because it'll just be subsequent podcasts, but I'm going to consider diagnostic reasoning and clinical reasoning. Now, while they may be mildly different, the available information is going to more or less point in the same general direction. Same processes will be involved because it's thinking and it's drawing on knowledge and making choices. I'm going to purposefully first look at what is occurring in medicine, generally speaking. So while this obviously is focused more on osteopathic manual therapy, I want to consider what's going on in medicine because as it stands, there is more information available there. There is a leading edge there, and then we can compare that subsequently to what is being done in osteopathy as far as we can identify. So I'm going to go through a few papers. I'm going to do my best to summarize them very, very broadly. So instead of reading a ton, I'll just sort of throw out the most salient concept, the most salient point, and then we'll talk to some degree, or I will talk at you, because that's how this seems to be working, about reasoning and how you can attempt to integrate these approaches, especially within the educational realm, or trying to train people within the osteopathic manual therapy realm, because the considerations within osteopathic manual therapy are luckily much narrower than in medicine, or even for a doctor of osteopathy. These are different fields. The realm of what needs to be known is luckily smaller in manual therapy than it is in medicine, because we're not actively utilizing pharmaceuticals, because that gets much more complicated. The danger profile changes. A lot of things change. Anyways, the first paper that I just want to kind of give a brief summary of, or the salient point, is a paper from 2017. The title is The Causes of Errors in Clinical Reasoning, Cognitive Biases, Knowledge Deficits, and Dual Process Thinking. The primary author here is Dr. Jeffrey Norman. He's the biggest deal. He's not the biggest deal. He's one of the biggest deals in medical education. He's done a lot with clinical reasoning, diagnostic reasoning, things of that nature. So he's the first author. The second author is my thesis supervisor, Dr. Sandra Montero, and then there's Dr. Jonathan Sherbino, who is also at McMaster, and who I've had the opportunity to meet a few times. The basic point of this is there is type 1 and type 2 thinking. So there is type 1, which is the intuitive or the fast, and type 2, which is the analytical. You could call type 1 non-analytical. The thing that has been suggested up to the point of this in 2017, or there have been groups attempting to support, is that the errors are in that type 1 heuristic fast thing, that fast approach. However, evidence would suggest that errors will come from both. There is further evidence that we'll look at a little bit later on that shows that if you get to the diagnostic faster, you are more likely going to be accurate. And the likely reason for that is you just know more, so you can get to it. Whereas if you are slower, you just don't know. So it doesn't matter how analytical you are or how slow you go. It seems as though if you just don't know, you go slow, right? So the thing here, the main point of this article is looking at those deficits and noting that both type 1 and type 2 errors will generate error in clinical decision-making or clinical reasoning. And it suggests, the broad suggestion at the end is with respect to educational strategies, and I'll read this. Educational strategies directed at the recognition of biases are ineffective in reducing errors. Conversely, strategies focused on the reorganization of knowledge to reduce errors have small but consistent effects. So the thing that's probably pointing at is what's called a semantic network, or a network of related meaning. So trying to generate ways in which knowledge will connect better, or how you can pull it into novel circumstances more effectively. And that's where that semantic network concept comes into play. But the key here is that cognitive debiasing and reducing biases, it doesn't have any net effect on reducing medical error or errors in reasoning. And the basic concept there that is most likely to explain that is that the person committing the error doesn't know they're committing the error, so they can't find it, right? So I'm going to move on to the next paper, and I'm going to click on this, and it's going to take a second. But, oh, no, it's not that bad. This article, again, this is from 2013, so this is earlier than the one that I just read. The other one was in 2017. The Etiology of Diagnostic Errors, a control trial of System 1 versus System 2 reasoning. This is Dr. Norman as a primary author, Dr. Sherbino, Dr. Kelly Dorr, I think, is at Mac. My thesis supervisor at the time in 2013 was still an MSc, so she is the final author there. I'm going to give again, excuse me, the primary finding there is that slowing down doesn't fix the errors, and accurate diagnosis is usually faster than inaccurate diagnosis. So you're slow because you don't know, right? It was done on second-year residents. There's, you can find this paper. You can definitely find the abstract. You may not be able to find the full text unless you have institutional access. But the main thing, and I'll just read the conclusion from the abstract here. This study demonstrates that simply encouraging slowing down and increasing attention to analytical thinking is insufficient to increase diagnostic accuracy. So again, if you're faster, you probably know more and you are more likely to be accurate. Whereas if you are slower, you just don't know. If you're slow, you don't know, right? That's as a simple catchphrase. So again, that type 1, type 2 thing doesn't seem to have any impact on accuracy or error. The next one, this is about debiasing again. Click on this, open link. I've just got this nice long note thing that I've been working on over time so that I have these easily accessible, even though it's going nice and slow. This is from 2013 again, and this is the title of this is Diagnostic Reasoning, Where We've Been, Where We're Going. My thesis supervisor is the primary author here, and Dr. Norman is the second author, so they would have done pretty closely together. Where are we at? Yeah, so this one, the general take-home here from this one, debiasing doesn't reduce errors, and there is signal that strategies to engage relevant knowledge does reduce errors. So the thing with being correct or making the appropriate decision is you need the relevant information to make the correct decision. If you don't have it, you can't do it. If you happen to know the piece of information but cannot bring it into the circumstance, then you can't use it. So you have the information, but you don't know that it fits. You don't use it, you can't make the correct decision. Well, there's a variety of ways in which this can be tested, and not all of these ways are going to be satisfactory to everybody who's going to pay attention to this, but overall, that's the stronger signal here. Now, the next one, this is about general thinking skills. So obviously a lot of what I'm going to be referring to is stuff that I know reasonably well, and that is going to be generated quite a bit from the faculty that I've had close ties with, because they're looking at the things that are relevant to this, and there's not a broad group that I'm aware of that had at the time been doing this work and really trying to challenge that System 1, System 2 approach, that cognitive bias approach. This is from 2019. The title is Critical Thinking Biases and Dual Processing, the Enduring Myth of Generalizable Skills. The big takeaway here, generalized thinking skills aren't a thing, at least for diagnostics. I would say that generalized thinking skills are not a thing for other areas. Specific skills will look like generalized skills. They'll look like they cross over. But a lot of times what's happened is that the person who has these specific skills has been doing stuff for a while, so they've probably gotten good at other things too. The other piece of this is that a large, organized, and retrievable knowledge base of both formal and experiential knowledge are the biggest deal, right? So just to I'll look back at this. Again, the author group, just so that I say this, Dr. Sandra Montero, my thesis supervisor, is the primary author, Dr. Jonathan Sherbino, Matthew Sibbald, who was on my thesis committee, and Jeff Norman was the final author here. And yeah, I am going to briefly read a portion here. I'm going to read the abstract for this one, because I think it will add some important information. And I'm not going to go through the whole paper, but I'm going to read the abstract. The context. The myth of generalizable thinking skills in medical education is gaining popularity once again. The implications are significant as medical educators decide on how best to use limited resources to prepare trainees for safe medical practice. This myth-busting critical review cautions against the proliferation of curricular interventions based on the acquisition of generalizable skills. Structure. This paper begins by examining the recent history of general thinking skills as defined by research in cognitive psychology and medical education. We describe three distinct epochs: the Renaissance, which marked the beginning of cognitive psychology as a discipline in the 1960s and 1970s, and was paralleled by educational reforms in medical education focused on problem solving and problem-based learning. Quick aside, problem-based learning, students like it. They say nice things about it, but it doesn't seem to do anything for performance. So with respect to using an approach that students like, sure, why not? It's not going to do anything to performance that we can identify. B, to read again, the Enlightenment, when an accumulation of evidence in psychology and medical education cast doubt on the assumption of general reasoning or problem-solving skill and shifted focus to the consideration of the role of knowledge in expert clinical performance. And C, the Counter-Enlightenment, in the current time when the notion of general thinking skills has reappeared under different guises, but the fundamental problems related to lack of generality of skills and centrality of knowledge remain. Conclusions. The myth of general thinking skills persists despite the lack of evidence. Progress in medical education is more likely to arise from devising strategies to improve the breadth and depth of experiential knowledge. You learn from doing, and when you have something to call back on that is specific to you, you are more likely seemingly to be able to utilize it. So with that network of related meaning, the ability to grab the appropriate piece of information that is germane to the situation seems to be improved by having done things, right? Now, the next one, where are we at? Yeah, this one is about reflecting on errors. So I'm going to open the link here, and I shall read in a moment. This one is from, when the heck is this from? 2015. So this is a little bit earlier than the one that I just looked at, which was 2019. This is reflecting on diagnostic errors. Taking a second look is not enough. And this is from 2015. Dr. Sandra Montero, my thesis supervisor, Dr. Jonathan Sherbino, and some other authors. It actually collapses them, and I don't know why. Dr. Norman's on there, Ian Mazzetti, Amin Patel. But yeah, Dr. Norman's in there again. So the main takeaway here is reflecting about errors. So this is an experiment. They were trying to ask people to reflect on errors. Reflecting errors does less for accuracy than knowing the right thing first. So if you don't know, you are slow. It doesn't matter if I ask you to reflect. You don't seem to be able to get there because you just don't know. I'm going to read the abstract here really quickly. Background: experimenter-controlled form of reflection has been shown to improve the detection and correction of diagnostic errors in some situations. However, the benefits of participant-controlled reflection have not been assessed. So the experimenter-controlled, I'm going to say this, the experimenter-controlled form of reflection is likely able to mobilize knowledge because of external input when compared to participant mediated reflection or participant controlled reflection. To read here the objective: the goal of the current study is to examine how experience in a self-directed decision to affect the accuracy of revised diagnosis. Design: medical residents diagnosed 16 medical cases on pass 1. Participants were then given the opportunity to reflect on each case and revise their diagnoses. Pass 2. Participants don't need that. Main measures. Diagnoses were scored as 0 incorrect, 1 partially correct, and 2 correct. Accuracies and response times in pass 1 were analyzed using an ANOVA with 3 factors: PGY, decision to revise yes, no, and case 1 to 16 averaged across residents. The extent to which additional reflection affected accuracy was examined by analyzing only those cases that were revised. Using repeated measures ANOVA with a pass 1 or 2 as within subject factor, and PGY or postgraduate year, and case or resident as a between subject factor. Key results. The mean score at pass 1 for each level was PGY. Yeah, I'm not going to read that. I will read this. While there was a trend for increased accuracy with level, this did not achieve significance. The number of residents at each level who revised at least one diagnosis was 12 of 19 PGY1, 9 of 11 PGY2, and 8 of 17 PGY3. Only 8% of diagnoses were revised, resulting in a small but significant increase in scores from pass 1 to 2. The conclusions. Participants did engage in self-directed reflection for incorrect diagnoses. However, the strategy provided minimal benefits compared to knowing the correct answer. Education strategies should be directed at improving formal and experiential knowledge. It seems as though for the accuracy part, knowing what you need to know and being able to bring it into the circumstance are more important than any form of reflection. To go back to this thing, this one is trying to see if interruptions would do anything. This is from 2015 again. The title, Disrupting Diagnostic Reasoning. Do interruptions, instructions, and experience affect the diagnostic accuracy and response time of residents and emergency physicians? Dr. Sandra Monteiro is the lead. My thesis supervisor, Dr. Jonathan Charbonneau. Kelly Dorr. I'm pretty sure Kelly Dorr is at Mac, or at least was. Dr. Norman's in there as well. The main deal here, time pressure and interruptions don't impact accuracy, but experience makes you faster and more accurate. So I'm not going to read through that one, but trying to interrupt people, put time pressure on them. If they know what they need to know, they will be accurate. If they do not know what they don't know, if they do not know what they need to know, it's not going to do anything, right? So the time pressure does do something to a person, but if you know what you need to know, you're probably going to be accurate. Do I need to do that? No, that one I don't need to do. I am actually going to do this really quickly. There is a paper. I saw this presented a few years ago at the Norman Education Research Day. The presenter was Dr. Matthew Sibbald, who was on my thesis committee. I'm noting these things just so that I can partially provide insight into proximity to the people that have written these things and that I have experienced this more directly, so that it's not just me likely having more opportunity to misinterpret the writing. I've actually had the opportunity to speak with these individuals. I've seen the presentations. So I have at least some increased confidence that my interpretation of what's written here has some value. So this is from, when was this published? Son of a gun. Come on. They don't put the stuff in the same place and it pisses me off. What? When was this? I don't know why it won't tell me. This was probably 2022 or 2023 that this was published. One of those. Anyways, the title is Should Electronic Differential Diagnosis Support Be Used Early or Late in the Diagnostic Process? A multi-center experimental study of Isabel. Isabel is an AI that is built for decision-making or diagnostics. So Dr. Sibbald, on my thesis committee, is the first author. Dr. Sandra Monteiro, Dr. Jonathan Charbonneau, Dr. Norman is the final author there. There are some other authors, but just to note those things. The thing here, if you're with respect to generating accurate diagnostics, there does seem to be at least some signal with respect to using the electronic help later. So after you've done a complete history and you've generated your initial hypothesis, then you can use some decision-making help in the form of an electronic resource to get the correct diagnosis. So your accuracy improves if you look for help seemingly at the end of the history and generating your initial hypothesis. But if you use it early, you're going to have more alternate hypotheses, which may or may not be a good thing for accuracy, but that's just generally the way it seems to be going. So there is probably way more information about the use of artificial intelligence and decision-making aids, especially electronic decision-making aids, but that's the one that I have some contact with. But again, it seems as though those who would likely, or those who were asked to use it at the end of the history, had more opportunity to be accurate, whereas those who used it to develop multiple hypotheses and did it early, so as things popped into their head, it could end up leading you down some funky roads. So accuracy, again, seems to be impacted by just knowing what you need to know, especially when you're going to use a support aid. Another one. Just trying to build a broad case here. So this one is from 2019, Debiasing versus Knowledge Retrieval Checklist to Reduce Diagnostic Error in ECG Interpretation. This is from 2019. Dr. Sibbald was the primary author. Dr. Sherbino's in there, Dr. Montero's in there, and Dr. Norman's in there as well. Where are we at? Yeah, cognitive debiasing and retrieval checklists basically don't reduce the errors. So I will read the abstract here. Okay. I'm going to read the abstract just so that this makes a little bit more sense. There is an ongoing debate regarding the cause of diagnostic errors. One view is that errors result from the unconscious application of cognitive heuristics. That alternative is that errors are a consequence of knowledge deficits. The objective of the study was to compare the effectiveness of checklists that identify and address cognitive biases, or promote knowledge retrieval as a means to reduce errors in ECG interpretation. Novice postgraduate year 1, PGY1, emergency medicine and internal medicine residents, 40 people. And experienced cardiology fellows, PGY 4 to 6, number is 21, were randomly allocated to 3 conditions: a debiasing checklist, a content knowledge checklist, or control no checklist, to be used while interpreting 20 ECGs. Half of the ECGs were deliberately engineered to predispose to bias. Diagnostic performance under either checklist intervention was not significantly better than the control. As expected, more errors occurred when cases were designed to induce bias. There was no significant interaction between the instructional condition and level of learner. Checklists attempting to help learners identify cognitive bias or mobilize domain-specific knowledge did not have an overall effect in reducing diagnostic errors in ECG interpretation, although they may help novices. Even when cognitive biases are deliberately inserted in cases, cognitive debiasing checklists did not improve participants' performance. The big thing from this one is that cognitive debiasing doesn't work. I'll hammer that over and over. I've noted it already a few times. Cognitive debiasing doesn't work. The person, regardless of how you get them through it, the person committing the error doesn't know they're committing the error. It doesn't work. Okay. The knowledge retrieval checklist for a novice. Let me read this. So the knowledge retrieval checklist might help the novice. Yeah, that's not a giant thing. Okay. Going to look at another one here. This one I've talked about in a variety of ways, so if you've paid attention, this paper has come up a few times. It contains some stuff that more recently have felt personal to me. Whether they should or not is a different story. They probably shouldn't. The title of the paper, The Three Phases of Clinical Reasoning, Epistemological Exploration of Disparate Error Reduction Strategies. This is from 2018. Dr. Montero is the primary author, Dr. Norman's the second author, and Dr. Sherbino's the third author. The EBM, so they're basically looking at ways to attempt to reduce errors. EBM, or epidemiological approaches to reducing errors, don't seem to do much as far as we can tell. I've done a lot of poking around on that, and I am pretty happy or pretty confident saying that EBM doesn't really reduce errors, at least not with how it's instituted. The fallback position of many people is, well, if you're using the best available evidence, the experience, the knowledge of the practitioner and the preferences of the patient, then you're doing EBM. There's a Mott and Bailey kind of deal where there's one thing that's built to look like it's important, and when people start to attack it, you run back to the thing that's actually important. You let them have the thing that's not important. The three-legged stool it's pretty weak, right? Everybody's going to use every evidence. Everybody's going to listen to the patient because they're required to by medical ethics, and everybody's going to use their previous experience. This is a no-duh thing, so it doesn't add anything, and it doesn't show much effect as far as I can tell. The cognitive debiasing stuff does nothing. That's in there too. They do look at that. The exemplar categorization model, so having an example that you can draw on and pull knowledge in from that, and having general categories to improve the semantic network, that seems to do something. It may not be perfect, but it seems to do something, at least at the time of publication for that, which was 2018. The next one, again, just trying to build the broad case with respect to understanding what's going on in clinical reasoning. Excuse me. And this one's going to be more about speed. This is eyeballing the use of visual appearance to diagnose sick. The lead author, Matthew Sibbald, Dr. Sibbald, Dr. Sherbino's in there, Dr. Norman's in there, and Dr. Montero. So they've done a lot of stuff about the type 1, type 2 errors, the type 1, type 2 systems, thinking fast and slow type stuff, as well as identifying what actually seems to be going on with respect to clinical reasoning. This one, it's about emergency physicians. Emergency physicians seem to display fast decisions with okay accuracy about sick or not sick, which lends support to a system 1 approach for initial hypothesis generation. So if you're going to use that type 1, type 2 thinking, please excuse me, at least for the hypothesis generation, because medical practitioners or physicians, regardless of level, generate an initial hypothesis, and then they go look for confirming evidence. That is the broad thing, and then that is contained, and that's talked about within the 3 phases of clinical reasoning. The epistemological paper. That's in there. So generally, the faster you seem to be, the more likely you are accurate. That seems to be general. In this one, the accuracy is okay with respect to sick or not sick. It was an experiment where pictures were flashed and just judged really quickly if that person was sick or not sick. But it's that initial hypothesis generation that then gets refined over time with follow-up. Right? The next one we look at is the impact of emotion on learners' application of basic science principles to novel problems. First author is Megan M. McConnell. Dr. Sandra Montero's in there. Dr. Norman's in there. Dr. Eva. I believe Dr. Eva is in Ottawa. Kevin W. Eva. I'm pretty sure Dr. Eva's in Ottawa. I might be going nuts. Then there is a PhD from who is at the Wilson Center, I believe, at U of T, Dr. Kulasegaram, who I've had very, very, very brief interaction in an online conference with, pretty knowledgeable PhD. So this one, again, the impact of emotion on learners' application of basic science principles to novel problems. It's very small data, and that seems to show that the affective state, so if you get somebody feeling very positive or feeling very negative, it seems to impact accuracy or learning. It seems to impact learning. I wasn't necessarily able to show that in my thesis experiment, which is, to some degree, I was hoping to be able to generate an experiment that would have some impact on affective state, but I didn't generate the experiment to do that. That was a hope. I didn't end up building that. I did something else. But it does seem to show that the affective state with respect to learning has impact. And that's probably, that's early learning. That's not necessarily the expert. So the novice, you can throw them off by getting them too up or too down. So just be cautious with that. Okay, this is the final one that I'm going to look at for this portion of this, small, tiny series on clinical reasoning. This is the inseparability of context in clinical reasoning. This is from 2024. The first author is Dr. Andrew Olson, and then we've got Dr. Montero as the final author. So there's quite a few authors in between. Excuse me. the general arc of this paper talks about a lot of the stuff that I've been talking about, the cognitive debiasing, the having appropriate knowledge, general cognitive approach to error reduction and clinical decision making. Excuse me again, this is killing me. The main point of this article is to start to broaden out the context to say that not only is the patient's input considered, but the location in which you are making the decision, which would include the administrative setting, the administrative rules, the boundaries, the requirements, so licensure requirements, the other social pressures, will all have an impact on the actual clinical decision making, right? Or clinical reasoning. So it's an addition in an important way to the general conversation about clinical reasoning, because there are other factors that maybe haven't been considered thus far, especially in experimental settings. In order to generate experiments, you do have to reduce quite a bit. You do have to narrow in order to meaningfully work on something, identify, to observe. So if you don't narrow in, it's not going to work out all that well. You're not going to be able to learn something, but you do have to take it out of context. And then as you put it back into context, now we have to talk about some different stuff, right? We have to add other factors in, try to see how they play. But when something is complex, we don't necessarily know how they interact in an appropriate way. So, or we can start to predict how each piece works, but we don't necessarily know how the whole system is going to work. This is a good general concept to include, that there are contextual factors, but it's true of pretty much anything. The variability in context is going to impact the decision making, the reasoning. So it's important to add into the conversation, and there's evidence that is being gathered to show how that happens. But yeah, things like social pressure, things like patient preferences, things like previous experience of the practitioner, these are all going to play a role. So with respect to accuracy in clinical reasoning, if you know more or you know the right thing, you're faster. The type 1, type 2 cognitive debiasing doesn't really do anything. We don't see any large-scale evidence of that. So the main things to take away from this portion are to be very aware that context is going to matter, right? That's the final thing that we're noting, that even adding pressure to people, trying to interrupt them, if they know what they need to know, they're going to be accurate. So if you're faster, you probably know what's going on. You're probably going to be more accurate. If you're slow, you don't know, right? And then cognitive debiasing stuff just doesn't do much. So hopefully that's built a general overview of what the heck is going on, or what's likely going on with respect to clinical reasoning. That's going to be a discussion of what the leading edge is. Obviously, you could argue that I'm looking at stuff from a very narrow group, and the reason is because that very narrow group is actually pushing the envelope of this stuff and trying to understand it better. Therefore, that is what I'm going to be presenting here. There are other things that are out there that would support the other ideas, but they're not the leading edge, right? So thank you for listening this far. Just remember, context is going to impact the decision, right? So the patient preferences, the previous experience of the individuals, the knowledge of the individuals, can they pull the knowledge in? If you're faster, you're probably accurate. If you're slow, you don't know. And cognitive debiasing doesn't work. Okay, it doesn't work. So thank you for listening this far. Hopefully you've learned something, and we will talk again soon.